So we will start the first session of the afternoon. It's entitled New Paradigm in MS. And I will first ask Professor David Miller to come, and he will be introduced by Professor Jean Pelletier.
Well, dear Gilles, dear colleagues, it's a very great pleasure for me and honor to introduce Professor David Miller. All of you know David Miller, and is currently Emeritus Professor of Neurology at UCL in London. He has been a recipient of numerous prizes dedicated to MS research, and is the current president of the Extremes. His major clinical and research interests are based on multiple sclerosis, and he works particularly on MRI to investigate new markers of the disease. As you know, he published a lot with a very high impact level. But I think that the most important to say is that he was the first one to initiate MRI study at the early phase of the disease and to follow these patients. He was also one of the first to develop new MRI techniques called non-conventional imaging, such as spectroscopy, magnetization transfer imaging, and diffusion and functional imaging. He was also one of the first to develop new techniques such as sodium MRI and to improve the mechanism we know in the disease with very high field MRI. You know, also he is a leader in many clinical trials testing and monitoring new treatments in MS. And finally, I think that I can say that David is a leader in the comprehensive evolution, MRI, and mechanisms of MS. Thank you, David.
Well, thank you very much, Jean, for those kind words. I would just make a note of the publication record. It's bimodal. It's a bit like the EDSS, and it's definitely on a downsweep of the second mode, having retired a year ago. I'd like to thank Gilles very much for the invitation to this special event. I first met Gilles nearer 30 years, or certainly more than 25 years ago, when I happened to be with my family on holiday, and I was persuaded to give a presentation in your department in Rennes, which was about a new approach to using MRI, short-term MRI outcomes, to assess treatment efficacy. And there had just been, in the year or so before this, an initiative, actually a European community-funded initiative with Otto Hommes at the lead. One of the activities in this initiative was to develop an imaging protocol for assessing treatments. And Gilles really responded to that immediately by applying short-term MRI to assess the effect of mitoxantrone in one of the first, if not the first, such trial to use this approach, which has since been used, I think, probably for all the subsequent therapies that have come along since the late 1990s, have been through this phase 2 screening approach to demonstrate proof of concept efficacy that then has been confirmed in phase 3 trials looking at clinical outcomes, particularly relapse rate. So, but I'm going to talk today about more about trying to, using imaging and to what extent it's helped us to understand the progression of the disease, looking in both the brain and the spinal cord. And I'm going to start off with a sort of a shorter part of the talk, discussing relapse onset MS, where I think things are a little clearer, and the imaging findings by and large have provided an explanation for relapsing disease. And then I spend a little more time talking about progressive MS, where I think there's still a big challenge to understand and monitor what's going on. So, as Jean did briefly touch on, there have been a number of studies. Probably the most consistent association between imaging changes and clinical evolution is what is seen in this slide, that people who present, young adults with a typical CAS, such as unilateral optic neuritis or a brainstem or spinal cord syndrome, about 2/3 will have disseminated white matter lesions that are clinically silent, and the presence of such lesions is associated with a high risk of conversion to clinically definite MS. That's to having another clinical relapse, effectively, although a few convert through becoming secondary progressive. On the other hand, a completely normal brain scan is a positive feature, and in the long-term follow-up studies, only around 10, perhaps 20%, 25% at the outside of such individuals have developed further clinical events. So MRI does seem to be predictive in this situation. Evolving out of this has been the development of the McDonald criteria, which is now later this year will be in its 4th iteration. And these McDonald criteria have used specific imaging features for dissemination in space and time to enable a diagnosis with the first clinical event. There's also been an effort to look at whether imaging correlates with or predicts future disability. Here the evidence is not as clear, but nevertheless there is evidence, and this is, I think, an impressive study from the very large and very important CS cohort followed in Barcelona, over 1,000 patients with CS, followed for a mean of 6.7 years, and showing that the baseline number of brain lesions, more than 10 lesions, was consistently predictive of developing EDSS3 at a higher rate than people with fewer lesions, and with quite long follow-up, getting out to perhaps 10 to 15 years. Even individuals who had started off with between 4 and 9 lesions seem to have a worse prognosis for disability. Wallace Brownlee and Olga Ciccarelli in our centre have been trying to look a bit more closely at the early changes following a clinically isolated syndrome, a smaller group of patients, 160 subjects who have been followed for 15 years. And this is looking at lesion parameters at baseline 1 year and 3 years. So on the top left is the number of supratentorial lesions, essentially a surrogate for the total brain lesion load. And one could see that the development of secondary progressive MS is more common in those who have accumulated more lesions during the first 3 years. If we look at the bottom left, we can see also there's an association of active gadolinium-enhancing lesions indicating blood-brain barrier breakdown with more acute inflammation. These lesions were also more common in those who evolved to secondary progressive MS after 15 years. On the right, what you see is the development of infratentorial lesions and spinal cord lesions. And you can see, while the absolute numbers are much smaller, about 10 supratentorial lesions for every 1 infratentorial or spinal cord lesion, nevertheless, those who developed secondary progressive MS had significantly higher numbers of new spinal cord and infratentorial lesions. And when all of these measures were put into a multivariate analysis, baseline 1 year, 3 years, and what came out of it was that it was the actual number of new spinal cord and new infratentorial lesions over the first 3 years that seemed to give the best independent prediction of development of secondary progressive MS after 15 years. Now this is, you could translate this into a more simple sort of numeric from this particular cohort, that if subjects had no new spinal cord or infratentorial lesions, the risk was about 1%, whereas if they had both a new spinal and infratentorial lesion, the risk was about 53%. One other aspect that MR imaging is not so good at, and particularly looking at the T2 lesion, is is the severity of the lesion in terms of how much axonal loss has occurred. And to investigate this more directly, optical coherence tomography emerged now, and really in the last decade, as a technique that can measure the retinal nerve fiber layer following attack of acute optic neuritis and quantify the amount of axonal loss. And as we see on this slide, there is quite a strong correlation between the extent of axonal loss following optic neuritis and the extent of visual function deficit, here shown by testing colour vision. And one can, on average, see a loss of about 20% of the nerve fibre layer following a single attack. That amount of loss, which is in this area of the slide, probably is compensated for, the visual effects are compensated for, and there's often quite a good visual recovery. But with greater degrees of axonal loss, there's clearly substantial visual impairment. So I think one could briefly summarize these observations in relapse onset to say that, in general, lesion load, activity, location and severity are all associated with the clinical course of MS. Of course, there is a lot of variability from one subject to another, but in general, I think these principles are reasonably well established in relapsing remitting MS and with some predictive value for the future clinical course. What about moving then on to the problem of progressive MS? Well, here I think the imaging came up against some perhaps unexpected findings, and this goes back more than 25 years ago. I'm thinking of Alan Thompson's studies in 1990 and 1991 particularly, that identified a discordance between MRI lesions and progression. And it's, I think, has been seen in both natural history studies and also when looking for treatment effects, and I'll show an example of that. But if people are in the progressive phase of MS not relapsing, they tend to have few new lesions, and if they have primary progressive MS, quite often they can have a small brain lesion load. And Alan Thompson particularly highlighted these findings in the early 1990s. If we look at an example of a discordant treatment effect, the recent fingolimod primary progressive MS trial, there was absolutely no effect of treatment on the progression of disability. Also, there was actually no effect on the development of brain atrophy, and I'll come back to that. But there was a highly significant reduction in the number of new T2 and gadolinium-enhancing lesions, a 73% reduction, concordant with what is seen in relapsing remitting MS. But the difference is here, perhaps, that the number of subjects and the number of active lesions was really quite small, by a degree, order of magnitude smaller than what's seen in relapsing remitting MS. And this treatment effect appeared to have no impact on the progression of disability. So we've heard from Hans Lassmann very clearly about the extensive pathology in progressive MS. White matter lesions, well, that's what I've been talking about so far. One's quite well able to image the white matter lesion, but the other aspects of pathology that are harder to image, very difficult, are these cortical grey matter lesions, which seem to be important, and of course the also ways of quantifying axonal loss, which occurs diffusely in the normal appearing white matter in the brain, and also can be diffuse and extensive in the spinal cord. So one technique that has been used really the most favoured technique to date for trying to get a measure of progressive neurodegeneration, neuroaxonal loss, is brain atrophy, a sort of an endpoint measure, as it were. Loss of neural tissue will inevitably cause brain atrophy. As we see here, the average tissue loss is about 0.5% per annum, but it is only a semi-specific measure of axonal loss. There are other physiological factors and also pathological factors that can cause fluctuations in brain volume. But this technique has been used increasingly in clinical trials, and I just want to touch on the trials of two agents that I think raise the question of whether neuroprotection may occur independent of an effect on inflammation. And here I'm confining the word inflammation to mean the new MRI lesion that's associated with the relapse. It's not referring to the compartmentalized CNS-based inflammation that is is very important in progressive MS. But I think it's interesting suggestive evidence, if we look at these two drugs, ibudilast, was briefly mentioned earlier today, was actually studied to see whether it would be effective in a standard way in preventing relapses and new MRI lesions, a placebo-controlled trial in a predominantly relapsing-remitting MS cohort, but unfortunately found that there was no significant decrease in new lesions or relapses. However, serendipitously, it was found that there was a significant decrease in brain atrophy in this trial. And we've just heard at the ECTRIMS late breaking news, a presentation from Bob Fox, reporting a significant reduction in brain atrophy also in progressive MS. So suggesting that maybe a mechanism of neuroprotection that is independent of new inflammatory lesional disease. And a similar observation in the simvastatin trial that Jeremy Chataway conducted. This was a trial in secondary progressive MS where there was 43% less brain atrophy in the simvastatin versus placebo arm, but there was no significant decrease in relapse rate or new T2 lesions. So I think these trials, again, are pointing to something different that's occurring in the progressive form of MS that is unrelated to the typical new white matter lesion that one sees on MRI. Well, atrophy occurs at all stages of MS, but there do seem to be areas of preferential atrophy development according to the stage of MS, and probably the most the clearest demonstration early on is thalamic atrophy, and this has been consistently reported in a number of studies. This is work that Bertrand Audouin from Marseille did when he was visiting us, showing that within 2 years of the onset of relapsing disease, there was already presence of thalamic atrophy. And even now this has been shown in patients with radiologically isolated syndromes. But if you look over the course of time at the patterns of accumulation of atrophy, this is work from Rick Rudick's group a few years ago at the Cleveland Clinic, and I think there are a couple of important points to make here. The first is that the rate of white matter atrophy is fairly consistently the same, whether it's seeing very early on CIS developing RRMS or late on developing secondary progressive MS. But when one looks at grey matter atrophy, we see that there is rather less occurring early on. Of course, it's probably occurring in the thalamus, but in terms of the total amount of grey matter atrophy we're looking at here, it's relatively less, whereas in the later relapsing remitting evolving to secondary progressive MS, there was significantly more grey matter atrophy occurring. And Leonora Fizniku, in a 20-year follow-up of one of the CIS cohorts at our group, identified that there is greater grey matter atrophy than white matter atrophy. Particularly, the most marked grey matter atrophy occurred in secondary progressive MS, compared to about twice the amount of grey matter atrophy compared to relapsing remitting MS subjects. And she also found that the measure of grey matter atrophy correlated significantly with disability measures, whereas the white matter atrophy measures did not. So quite an emphasis then on the importance of grey matter atrophy starting early, but becoming pronounced in secondary progressive MS. Now, what's the basis of the grey matter atrophy? Well, likely it is the cortical lesions that we've heard about that are very frequently found in post-mortem in secondary progressive MS and prime progressive MS, but are very, very difficult to image. This is an image at 9.4 Tesla ex vivo, 128 minutes or 130 minutes, and a resolution that's quite inachievable in an in vivo study at 7 Tesla, or barely achievable, and certainly the amount of time that one would need to get this type of image isn't tolerable. So at present, the imaging of cortical lesions, I think, is still problematic, particularly the imaging of subpial lesions, which probably we think may be the most important ones in that they are related to meningeal inflammation, which in turn may be an important mechanism of progression of MS. So another possible approach to look for subpial abnormalities would be to use magnetization transfer imaging. This is a quantitative measure. It's easily acquired, and it tells us something about the macromolecular structure and content of tissue. And in there is a concentration, there is a correlation of the MTR with the myelin content that's seen in both the white matter and in this study from Jacqueline Chen, also shown in the cortex. So we applied that to an in vivo study. Becky Sampson did this study and segmented the cortical ribbon into an outer and inner 50%, the results of the study were that compared to healthy controls in relapsing remitting secondary progressive and primary progressive MS, there was abnormality throughout the inner cortex of a similar degree, but in the outer cortex there was substantially more MTR abnormality occurring in secondary progressive MS. So I think this would be consistent with more extensive subpial demyelination, albeit inferential. Declan Chard, stimulated by the observation of an abnormality at the CSF brain surface, at the cortex, wondered could there be a similar preferential abnormality occurring at the periventricular surface, and he performed this study a couple of years ago with Xing Lai using high-resolution 1 by 1 by 1 millimeter MTR images around the upper part of the body of the lateral ventricles. And what he found was that in healthy controls, the MTR is highest adjacent to the ventricle and then slightly decreases as one moves out. But in MS, the lowest measures were seen at the ventricles and then tended to stabilize as one moved out. Relapsing remitting MS was abnormal, but secondary progressive MS showed a greater abnormality. So this suggests that there is something occurring quite intimately within the first millimeter or 2 or 3 from the periventricular surface. Again, more prominent in secondary progressive and relapsing remitting MS, but the fact that it's there in relapsing remitting MS suggests there may be a disease mechanism that's operating from early on. What that is, I think, is a very open question. Another way for looking at neurodegeneration and demyelination is sodium imaging, which Jean briefly mentioned. Just to discuss of course, the normal physiology, sodium is in low concentration intracellularly and in high concentration in the small extracellular space of the normal brain. But in MS, there are 2 things that happen that affect that. One is there is demyelination with aberrant sodium channels, which leads to an accumulation of intracellular sodium. The second is that there is axonal loss, which expands the extracellular space and leading to an increase in extracellular sodium. Sodium, 23 sodium is MRI visible, of course in a much lower concentration than for proton imaging, but one can obtain these images up above, and one can see immediately in MS, and particularly in the progressive forms of MS, a rather diffuse increase in the concentration of sodium. So it's certainly conspicuous in lesions, but also it's clearly increased beyond lesions. And David Paling, several years ago, studied this in more detail and found that in secondary progressive versus relapsing remitting MS, sodium concentrations were higher in lesions, normal appearing white matter, cortical and deep grey matter. And he also found that there were significant correlations of the sodium in T1 black hole lesions and in the deep grey matter with disability. So I think another measure of likely neurodegeneration, extensive neurodegeneration, demyelination, that's associated particularly with secondary, but also with primary progressive MS. So for the remainder of the talk, I'll try and switch a bit more quickly to just discuss the spinal cord and MS. Of course, terribly important in terms of the clinical impact, whether it's relapses or progression of MS. More challenging to image. Here is an old cross-sectional slide of the type of lesions that occur in the spinal cord, and the important point here is that the lesions can be very small or very extensive. They have a preference for the posterior and lateral aspects of the spinal cord, but they don't respect the grey matter boundary. Lesions often cross extensively into the central grey matter. And also there is can be extensive axonal loss in the spinal cord, particularly in progressive MS, both in lesions and also in the normal appearing fibre tracts. So spinal cord atrophy has been studied extensively for over the last 20 years, and I just highlight one example from the fairly recent literature from Frederick Barkoff's group, a very large cohort study, which showed that there is significantly more upper spinal cord atrophy in primary and secondary progressive MS than relapsing remitting MS. The two progressive forms of MS are rather similar, and that smaller loss of cord area is associated with higher EDSS. And generally, the correlations of atrophy in the spinal cord are stronger with EDSS than they are correlations with brain atrophy, which shouldn't be surprising, as the EDSS is quite oriented towards locomotor involvement. There has also been a study of grey matter atrophy in the spinal cord, a difficult thing to measure, but this group from San Francisco, Dr. Schleger and college, did manage it, and they found that it was the atrophy in the grey matter that was more strongly correlated with disability, similar to the observations that we've seen in the brain, and that the main explanation in a multivariate analysis, the main explanation of disability came from grey matter atrophy. Now, the imaging of spinal cord lesions has been more challenging, but I want to just briefly talk about what can be possible. It takes about half an hour to collect these two scanning sequences, high-resolution images through the cervical cord, 0.5 millimeter in plane resolution, T1 and T2 weighted sequences, and one can see the lesions pretty clearly. Again, you can see they're clearly not just, they are involving lateral posterior columns, but also very often extending into the central grey matter, rather similar to the pathology slides of Oppenheimer. And so applying this type of approach, one can measure the lesion load in the spinal cord and can also measure the effect of loss of spinal cord tissue, and so try and get some composite assessment that takes account of atrophy and the lesion load. And when Hugh Carney did this, what he found was, looking at secondary progressive MS, he found the highest lesion load of the three MS groups. PPMS came in intermediately. He also found the greatest atrophy, the smallest cervical cord, and when one looked at this percentage of the spinal cord area covered by lesions, it was almost 30% in secondary progressive MS, about 20% in primary progressive, and only about 11% in relapsing remitting MS. He found in a multivariate model that also included brain measures which tended to go in the same direction, more brain atrophy in secondary progressive MS, higher lesion load. But when all of these measures were put into a multivariate analysis, it was the cord lesion load and atrophy that provided independent prediction of disability. So I think these measures could be important for understanding, but also for following people with progressive MS in clinical trials, for example. Hugh Carney also looked at used diffusivity, MR diffusivity scanning to look for abnormalities in the grey matter as well as the lateral and posterior columns. And what this slide shows was that there is diffuse abnormality of radial diffusivity, which gives some idea of the length to which protons are freely mobile between tissue structural boundaries. You could see quite clearly there are abnormalities in relapsing and secondary progressive MS, more so in secondary progressive MS, but that in the multivariate model, it was the combination of spinal cord atrophy and grey matter radial diffusivity that independently contributed to EDSS. So the grey matter probably has some importance. And one final piece of work that we did was to consider, could there be meningeal inflammation occurring in the spinal cord, and could there be preferential damage to the outermost layer of the spinal cord that might be important in pathogenesis. And there has been this study several years ago which reported, I think Richard Reynolds' group, reporting an association between CD3 cells in the meninges and axonal density in the spinal cord, suggesting there could be a relationship. So Hugh Carney, with help from the physicists, obtained high-resolution MTR images. These are the standard T2 maps. And what's found in the normal situation, just at the very edge of the spinal cord, is that the MTR is actually higher than in the spinal cord itself. And this might reflect the fact that there is some collagen in the pia mater, but there's probably a partial volume effect. It may affect also a greater concentration or compaction of myelin sitting in the outermost layers of the cord. Whether it's either of those, you can see from this slide how this single layer, voxel layer, 0.5 millimeter diameter in the outermost cord is higher, of course, than the surrounding CSF, where it tails off quickly, but also than the grey and white matter in the spinal cord. And what Hucani found was that in all MS subgroups, there was a lower outer voxel MTR compared to controls. He also found a decrease in relapsing remitting MS in the absence of cord atrophy. We could just hypothesize, and these are only hypotheses, that meningeal inflammation may precede axonal loss. He found a lower outer cortical cord MTR and progressive than relapsing remitting MS. One might hypothesize that more meningeal inflammation is occurring in progressive disease. And he found an independent correlation of the extent of outer voxel MTR abnormality with cord atrophy, suggesting that there could be a direct relationship between inflammation leading to axonal loss. So these, of course, are only hypothesis generating, but I've come to the end of the talk, and if I was to summarize, I think in relapsing remitting, relapse onset MS, there's reasonable evidence that lesion parameters and their various guises are associated with the clinical course. But in progressive MS, there are multiple MRI measures associated with progression, and by and large, these reflect neurodegeneration, atrophy, and the involvement of cortical and deep grey matter, normal appearing white matter, and also, very importantly, spinal cord. There do seem to be some MRI abnormalities preferentially adjacent to the CSF spaces, which raises a question: is there a pathogenic mechanism perhaps arising from CSF, or is there some other relevant mechanism that might help us to understand disease evolution? So I want to finish there. Thank Gilles again very much for the opportunity to attend this symposium and to acknowledge the group I work with in London. Thank you.
Okay. Thank you very much, Professor Miller. Unfortunately, we are running out of time, so there won't be time for questions now. And as a well-known specialist and expert in the field of multiple sclerosis, it's my pleasure now to announce the next speaker, Professor Ludwig Kappos, which will be presented by Professor Marc Debouverie from Nancy. Please.
First, Gilles, many thanks for this very fine day. I am very pleased and honored to welcome among us today Professor Ludwig Kappos. His world-class work doesn't have to be described here. It is well known to everyone present today. Professor Kappos is to us all the one who harmonized clinical assessment in trials and EDSS scale. Many thanks for everything, for all as of this. I would like to take advantage of your presence today to ask you to think about three particular aspects. Over the last 25 years, we have noticed that the two main endpoints, annualized relapse rate and EDSS, have changed over time. Considering this, we have to rethink the statistical power on trials and the increase in number of patients, probably. However, shouldn't we also consider changing or adapting endpoint? These figures show us that the annualized relapse rate decreases and the EDSS is less subject to change over time. Second is NIDA. NIDA is a composite outcome. MRI lesion activity, relapses, and disease progression are used to define NIDA. NIDA, or an other terminology, as friend Lublin has said this morning. However, these three measures don't evolve the same way over time. Most of the non-NIDA patients are considered non-NIDA because of MRI activity criteria, especially in the short term. What do you think of an evaluation combining such different factors? That's the question for you. And the last, what's here our collective responsibility as neurologists and as researchers when communicating about trial results? Patients with progressive MS or patients with significant impairment are constantly waiting for research to progress and improve their quality of life. It's absolutely not normal. Recently, ocrelizumab and ciponimod have shown slight advantages. In PPMS, there's 6% lower of increase of disability for patients with ocrelizumab after 3 years of treatment in comparison with placebo group. So, in order to find treatment efficiency for one patient clinically stable after 3 years of treatment, non-improved, stable, 16 patients, we have to be treated at least 3 years. My question is, how may we communicate these results, relative versus absolute measures, number needed of treats, and so on, including medico-economic aspect? I would like your opinion on these points, and many thanks for your contribution. Bitte.
Well, it's a special pleasure and, of course, honor to be here in this President's Day because, of course, I feel very attached to our neighbors and colleagues in France from Switzerland, living at the border to France, but also due to my personal relation to your president and Gilles Edan. I think we met the first time in the early 90s in some advisory boards, and I always was fascinated by your enthusiasm, your sense for innovation and for new concepts, and the deep concern for the patients that you were caring for. And I think that's a very good example how we can combine care for our patients and advances in research, in clinical research. And I think you are a good model, and you see how many of the people who worked with you have now influence in the field, and how your concepts have had an impact on the field, so it must be also very satisfying to you. In the introduction, I was also acknowledged as someone who helped in standardizing clinical assessments. This was the positive view because, as you may know, or at least those who experienced that, it's also a kind of pain in the neck of doing this kind of exercise and obeying these rules. And I think it was a little bit a revenge by Marc that you asked me these very difficult questions that, of course, I doubt if I will be able to answer. But anyway, I think there is no doubt that we have had significant progress over the last 20, 30 years in MS, in clinical research, and especially in developing new therapies. And this has been associated also with collaboration with different companies, and you see that. No personal, at least pecuniary interest in that, but there are many companies also involved in the way we decide and we develop new treatments. I will provide a little bit an historical perspective on that, discuss the current paradigms for phase 2 and 3 studies in relapsing, remitting, and progressive MS, key achievements and learnings from clinical studies, and try to reiterate on something that I think is very important to understand, that it is always a bench to bedside, bedside to bench relation that we have had from clinical studies and basic research, and finish with a short outlook of what I think is the next phase. So if we try to categorize the development of modern MS therapy, I think we can have 3 phases, and we are now at the end of the second, in my opinion. The first, the concept of immunosuppression and immunomodulation with courage, but also accompanying skepticism in the first years, and RENNES and people working here have had an important role in that. Then biotechnology enters the field, and evidence-based medicine with concepts. So I think we can call that the golden era of controlled clinical trials in MS, and now we need something more. We need to have a synthesis of clinical trials, but also systematic observational studies, and to combine that with the concept of big data analysis, and finally approach personalized medicine. So this is a tribute to the pioneers of immunosuppressive treatment in MS. There was a conference in '77 already where Otto Hommes, the founder of ECTRIMS and the Charcot Foundation, summarized at the end 42 reports, most of them observational studies, approximately 500 patients. 40% were improved, 25% stable, better response in young patients with short disease duration, high CSF, IgG, and of course the need out of all these discussions, we need to have control groups, we need perhaps even a double-blind design, or is it, can we rely on pre and post interventional observations? And this was, I think at this time, Joël Auger, who is also present here, and later also here on the podium, and Savoureau, and of course Gilles Edan, as a youngster at this time, was also involved on that. Then out of these discussions, first clinical controlled studies were started, mainly dealing with comparing azathioprine with placebo, cyclophosphamide, and the only North American controlled study at this time on this subject. Then cyclosporine as a new, more immunomodulating than suppressing agent in our view, in Europe against azathioprine, and in the US against placebo, with not very convincing results. And I think the real starting of the golden era then was the introduction of interference in '93 in the United States, and then you see the continuous development and the acceleration of development of new compounds as approved treatments of relapsing remitting multiple sclerosis, and starting. So we can say that we have had an era where we have an improved methodology of phase 2 and 3 trials with a parallel design and placebo-controlled. MRI activity was shown, and this was spearheaded by David, also with this common initiative and guidelines in 1990, where he was the first author from Magnims, proposing the frequent MRI paradigm for testing new therapies in multiple sclerosis. And then and we were lucky enough that this paradigm was really predictive, highly predictive of what would then happen in phase 3 studies, and also with a real effect on clinical outcomes. We have a number of new compounds, some of them previously not expected mode of action, or that we are currently trying to understand and revising our concepts sometimes again and again. And we now have also a first glimpse of hope for progressive MS. But the most important contribution, as I mentioned already, is that we have new insights in the pathogenesis of the disease. So first of all, the principle of the role of the immunopathogenesis was made with these trials in the human disease. We have better understood the role of different components of the immune system. Blood-brain barrier was a very important first understanding, and also therapeutic consequences, the respective roles of T and B cells. You heard already today some of the most recent insights on that, natural killer and regulatory cells, macroglial activation in the pathogenesis. All these aspects have been brought to our attention through therapeutic testing and understanding the mode of action of different substances. And we also understood that different phases of the disease will not respond to the same treatment, that we must adapt our therapeutic approach. One of the main insights that has developed over time, and of course could have been conceived earlier, but we have seen also in clinical trials, we see in daily practice, is that our observation, when we try to correlate our findings with the clinical picture, when we try to relate that to disability, we are always deceived by the compensation potential that especially young people or in the early phase of the disease have, and which covers the real effect, even if we accept that there is a continuous or intermittent destructive process underlying. So we may see something or be happy with the results of therapy without this being the truth and without being reflective of what will happen in the future. So when we look at short and mid-term, we should understand that it is something complex that we are looking at, something that is on one side, the destructive process, on the other side, the compensation, repair, regeneration capacity that is in the respective individual. And this is true for both health professional assessed and for patient-reported outcomes. At the long term, we understand that this will come together again, that will again converge, but at this time it may be too late, and especially when we are assessing new therapies. So the question about correlation to clinical findings is always relative for me. The key question is, do we really address the key pathogenetic factors in the disease? And the better we understand them, the better we can also assess new treatments. And we, as I already mentioned, with a paradigm of inflammation in the early phase, with focal inflammation that we image with gadolinium-enhancing lesions, with new T2 lesions, we were quite lucky to catch at least a part of important pathogenesis for this disease, but we must expand in a better understanding and assessing demyelination, axonal neuronal loss, and perhaps even loss of synaptic plasticity, the functioning of functional networks, if we want to assess the disease and measures that we take in order to fight the disease in a better way. So this model of short-term evaluation over 4 or 6 months with frequent MRI has been a good paradigm in MS, and we have complemented that by a long-term follow-up where we also gather some additional safety data over time when then, based on the results in this first phase of frequent MRI, we embark into the phase 3 of development. And this is a typical example with fingolimod, where you see the effect and also and information about the dosage that came unexpected when we completed this study, and then the follow-up where we see those who had switched then from the placebo group to the active group come to the same level, and you see also a sustained effect. So this is quite informative of the effect on inflammation. And if you look back, has been instrumental in development of all these substances. There is no single substance out of these, perhaps alumtuzumab to partly, that has not benefited from these proof of concept studies that then led to the higher investment in time and in resources for phase 3 programs. The question is, can we improve on that for relapsing MS? There have been attempts to use the same endpoint, but with smarter designs, allowing for shorter duration and better dose estimation. And a good example that was mentioned already by Hans-Peter is a study for siponimod in relapsing MS, where we have used a design with several dosages in a staged approach over time, and we're quite well in a position to define the optimal dose to be taken then as a single dose in phase 3. Another, of course, can we have something that is cheaper, easier to standardize, alternative endpoints to MRI? And this is, of course, something that is of interest, still of interest, and an example of what something that may be emerging has been presented at the last ECTRIMS by Maria Pia-Sormani, who studied the role of a possible putative role of neurofilament light, a specific constituent of neurons and axons in the blood, measured in the blood as a replacement or a substitute for what we have done in this paradigm of gadolinium enhancing or new T2 lesions. And what are the requirements if we want to assess a phase 2 endpoint? First of all, it should be easier to measure, so have practical advantages and perhaps to standardize. It should relate to clinical endpoints, so have a correlation to them. Should be affected by treatment. We should see the treatment effect, and the effect of a treatment on this variable should predict the effect of the treatment on clinical endpoints, so the surrogacy. And this is just an example based again on the fingolimod phase 3 study against placebo. You see that indeed you see the effect of the drug here after 6 months. Already there are lower levels, clearly statistically significantly lower levels of neurofilaments with fingolimod than with placebo. So first prerequisite is met. Correlation to clinical endpoints is there. This is the correlation to T2 lesions, then to brain volume change after 24 months. Then neurofilaments and relapses over 2 years. Again, the higher, the more those with more relapses have higher neurofilament levels, and there is also a correlation to a change in the EDSS, so disability progression-free survival over time, over 2 years, if you look at the neurofilament level at 6 months. And this is, you see here, no, this was the thing, disability here just in large again, and you see the comparison, active T2 lesions at month 6 and neurofilament light levels. You see the predictive value with a hazard ratio of 1.6 or 1.7 is both, for both statistically significant and acceptable. It is perhaps interesting to see this last figure from this piece of work that I wanted to present here, which is the proportion of treatment effect that you can explain by the marker after 6 months. And you see regarding relapses, it is nearly, or it is identical. The percentage is the same as with MRI lesions, 30%. Regarding percent brain volume change over 24 months, you see that the predictive, or the part that is predicted by neurofilament levels at 6 months is clearly higher. And this is perhaps interesting that we may add something to what MRI is able to tell us, if this, of course, is supported by further studies. So perhaps an emerging new proof of concept outcome that may, of course, because it reflects, as we see here, more the real damage that happens, may also also be applicable for progressive disease. So the current paradigm of phase 3 studies in MS is this clinic for phase 3. Now when we go to phase 3, parallel randomized 1 to 3 year studies, moving of course from placebo to active comparator, and trying to assess clinically in the best possible way. At the moment, we keep the EDSS, but attach an E to that, so an electronic support in making consistent ratings, and also, of course, other more symptom-specific measures, including neuropsychology. But we need also in phase 3, and this is something that is underestimated, unfortunately, frequently by the sponsors of these trials, we need also the biomarkers that approach the pathogenesis of the disease to better define the responders, and also to support, of course, the consistency of the results. But you see that here in green. These studies have become more and more expensive, also because of this phenomenon that was just alluded to in the introduction of a lower frequency of events. And it seems to be quite inappropriate for the assessment of combinations and treatment strategies. The more complex the approaches are, the more these are management strategies. This classical design will not help us, and of course it's not good for long-term assessment, which is certainly very important in multiple sclerosis. So we have also learned with all these euphoric, presentations that I did up to now, we have also learned that with the changing landscape, we must be cautious in comparing clinical trials, and that even the same clinical trial, if done in a different setting, may result in different results. And this is just the equivalent to what has been shown in the introduction. You see the same agent here, interferon beta 1a, interferon sub-Q, IM, and 1b. Over time, the same substance, much lower relapse rates. So you would perhaps conclude that the same substance is becoming better and better and more effective. But of course, it has something to do with the selection of our patients, and this and other, not anymore so recent, but impressive example of a divergence of results. 2 studies with dimethyl fumarate, one that shows a significant advantage regarding disability worsening or progression, and the other that doesn't show a difference. The difference lays in the completely different behavior of the placebo group, although the inclusion criteria were nearly identical. And that was an early frustration for us when we conducted secondary progressive MS trials. Again, the same substance here, interferon beta 1b, showing a significant delay in disability progression, and here in the North American SPMS study, the same compound without an effect, and even placebo behaved better. Of course, if you look more thoroughly, you see there are different subgroups that have been in different composition in this specific secondary progressive trials, but still, that's something we have to take into account. So the question is there, and this was also asked in the introduction, NIDA as a possibility to summarize what we find and to compare perhaps treatments with each other. So it is quite something that has face validity. Everything you can see for activity of the disease in a certain time period, 1 year, 2 years. Is it there on yes or no? So it's quite simple. There have been contradictory results in different studies regarding the validity for predicting the future. So is the effect really assessed sufficiently with such a measure? First of all, it's good to use this measure because we see impressive results. You see here with the oral drugs, effects that reach up to 50% of the patients who are stable or do not show any signs of disease activity. And of course, you have to compare with the placebo group also, which also reaches that, but it is statistically certainly better, and with monoclonal antibodies in general, even better, these results. And they may, regarding the criterion of NIDA, also be an underestimate because, and this has been shown quite impressively with the ocrelizumab studies in relapsing MS, where we see that in the first 6 months, when we count T2 lesions, we still count some of the lesions that occurred or were generated in a time when the treatment had no chance to influence the pathogenesis. And if we re-baseline the patients and we look what happens after the first 6, here is the 6-month assessment, here 1 year, 2-year assessment, you see that we have a complete effect. So these figures may be even better if we take this into account. But on the other side, they are biased towards inflammatory activity, and this may not be sufficiently reflecting the real pathogenesis, long-term pathogenesis of the disease, and that's why we had proposed for group comparisons the brain volume change as an additional measure. And you see here again with the fingolimod studies the respective contribution of the different parts of NIDA. You see T2 lesions have the major contribution, so most patients are lost with this criterion, some more with relapses, but much less are added from 34 to 31% if we add disability worsening or progression. So the contribution of this is quite low, and only when we then add brain volume change more than a certain level, then we reach a real additional number of patients that have not been covered by the inflammatory activity. And of course, it shows us also that we are far away from really stopping the disease in a more complete manner. This criterion, at least in our hands, was more predictive for disability progression. So if we use NIDA-4, we had a better assessment of disability progression, while the predictive value for relapse activity was similar or perhaps inferior to that with NIDA-3. And as I made the argument already with the work of Pierre Sormani, we think that we need additional measures, perhaps NIDA-5 with blood neurofilaments and other markers to come. So to summarize at the end of my presentation, I think all here have no doubt that there have been important and clinically relevant progress by applying the current paradigm of corporate-sponsored controlled trials in relapsing remitting and also partly in progressive MS, but that as we are moving towards comparative studies exploring the relative merits of more and more diverse and complex treatments, we need to combine controlled randomized trials with prospectively planned, thoroughly conducted, comprehensive observational and cohort studies. And this must be more than independent of corporate sponsors, more investigator-initiated and publicly funded studies. And I think you have a very good example of something that is also publicly funded with the EDMUS initiative and the network that prospectively follows patients. And I think again here, together with Christian Confavreux and the Lyon group, now headed by Sandra Vukusic, RENNES and Gilles Edan and your group have been instrumental in developing that over time. So you have already started with that in a very efficient way, and it's coming more and more that we have investigator-driven networks that function as a central resource and facilitate the implementation, but also the further development and refinement of cutting-edge methods for time and cost-efficient evaluation of therapeutic interventions. And now we are moving to improving clinical practice by using these methods and these cohorts to define those patients who may most probably benefit most of the new interventions and treatment schemes that are coming up. So that was the end of my presentation. Thank you for your attention, and I want also to acknowledge our group in Basel, who of course also confer the greetings to the audience, but especially to the president of the society, Gilles. Thank you for your attention.
So I will now ask Professor Michel Clanet from Toulouse to come for the last presentation of the session, and he will be introduced by Professor Clavelou from Clermont Ferrand.
Perhaps I will have the first slide. Thank you. Thank you very much, Gilles, to inviting me to introduce Michel. Michel, it's a difficult task to speak about your different lives, and I want to summarize them, if I can, in a few minutes. You show a few years ago that it's possible to have a double cursus, medical and PhD, a long time before it was obligatory in France. You're a professor in neurology at the University of Toulouse and rebuilding the neuroscience department. The number of papers is more than 200 in the different fields: genetic, immunology, clinical and MRI classification, and also clinical trials, and finally about patients. And those led some to give you the chairman of the scientific committee of ARCEP during 10 years, modernize this committee, the expert of the French Agency for Drugs, and also the coordinator during 5 years of the French group on research on genetic. But you have also other mandates at the OD board of Charcot Foundation, of International Federation of Multiple Sclerosis, and also at ECTRIMS, Society of Immunology, and you built also the new European Academy of Neurology. And everybody remember the very nice meeting in Toulouse, the 16 ECTRIMS meeting. And you was the chairman of ECTRIMS during 3 years, and then the president of ECTRIMS for 3 next year. But you are also courageous. You can climb, perhaps cultivate desert, or navigate in strong wind. But you know that professional life is not so easy sometimes, if you remember with Gilles. But you have some kind of visionary. This is during the meeting in Lyon, when we were 200, the ECTRIMS in 1987, but also tenacious. Tenacious not only in MS, and now it's probably when you try to explain the offside in rugby. Those qualities led to main official duties in France as a chairman of the French Collège des enseignants de neurologie. And you show that you are very approachable with a very overview of all the neurology in France. Chairman of the Scientific Committee for the Fédération pour la Recherche sur le Cerveau, Fédération Française de Neurologie, French Society of Neurology during 1 year, Chairman of Conseil National des Universités, and Executive Board Member of OFCEP. During all this mandate, you show that you are able to promote new experience as the birth of the new French Multiple Sclerosis Society. Thank you very much for that. But also that you act as a godfather. And this is why, for this large experience, the Ministry of Health gives you the responsibility of the neurodegenerative disease national plan for 5 years. I don't know how you can do to spend different lives in one, but probably you draw in your energy in your family, which is so close to you. Now, thank you for all you have done, and all you have done with your patients, with a real empathy, and all you have done and you do for the neurology. Thank you, Michel.
I guess something happened in my collection of familial pictures. I don't know why. Thank you very much, Pierre, for this kind presentation. And thank you, Gilles, for your kind invitation in this brilliant panel of speakers. So the question you asked me was, is something has changed in the 25 years about the patient care system? And so I will start with the late 70s and the early 80s by this experience of Alexander Brunfield, who was a psychiatrist and who wrote his personal experience in the British Medical Journal. I don't want to read all the things, but you see he was affected by optic neuritis, typical optic neuritis, and he said that he saw several doctors over some weeks, but none encouraged me my questions or seemed to be aware of my emotional needs. And he was told that he could read the textbooks and he knew as much as any doctor, and that only time would tell. And after 5 years, he has a new relapse. He saw a neurologist, and this neurologist told him that he had multiple sclerosis. And Alexander said that this definite diagnosis was a relief to me, and I was grateful to this man's frankness, and so on. So what this experience teaches? It teaches that in the 80s, usually the diagnosis was performed lately. The diagnosis disclosure was not very good. We had few treatments, steroids, in some centers, particularly in Rennes, with Olivier Saboureau and Gilles Edan. Some patients had azathioprine, and some people were treated by cyclophosphamide. I remember that in the 70s, Otto Holmes treated some patients with thoracic canal duct catheterization, if I remember well. So it was difficult to take care of patients at the moment. And this happened it was the introduction of the treatments, the treatment era. I think I don't want to speak about the treatments. Ludwig did that very well. But I would like to say that when a treatment appears in the field of disease, there is something new. There is a treatment. And this treatment gives a very good, interesting approach for health care of the patients. And I think that in the pharmaceutical company at the moment, in the early part of this treatment eras, were very, very powerful to give us the possibility to be interested not only in the treatment, but in the patients. This was the first conference de consensus, which is consensus meeting, which is the way we did the guidelines at the moment. It was the first time we were interested in guidelines in multiple sclerosis, not only how to use the treatments, but also how to take care of patients, not diagnosis disclosures, and the daily care of the patients, and not only in the aspect of medical care, but also of social care. I had the chance in this period to be involved in a special group of friends, which was MS Forum at the moment, and many of the speakers who are here today were in this group. And we did a lot of work to improve the teaching material, which is given to all the neurologists to be involved in the interest of the patients in the center of care. And in 2006, for the first time, the possibility of reimbursement of all the health costs was decided by the health authority, which is a special way to evaluate which patients will be reimbursed totally for the health cost and for the and partially for the social cost of the disease in their environment. Finally, multiple sclerosis is a chronic disease, and like all the chronic disease, we think about what is the ideal model for healthcare. And if you ask different people, the ideal model will be different according to if you are the funding institution, if you are the neurologist, if you are a social worker, or if you are the person with the disease. And you know that the expectations between the patients and the neurologist are sometimes different. Many papers have confirmed this. I think that the ideal model for healthcare is a model that the care outcomes which achieves daily improvement of patients' quality of life. There are some, we know that there are different needs for patients according to the different stages of the disease. And if you see the pathway, longitudinal pathway of the patients, you have to take in charge the different needs at the different moment in a seamless pathway, which is very important for the patient and which is important in public health also. A comprehensive team, you said team yesterday, Gilles, team, a comprehensive team or organization which can respond to the following needs: medical needs, social needs, educational needs, vocational needs, and emotional needs, which means that many systems of care are involved at the moment in the longitudinal pathway of these patients. I don't want to define these different care systems, but MS patient can be facing this different system of care at the moment. I think it is so important to think about not only the patient in the center, but also the caregiver, which is very important also. And the number of specialists who are involved at the moment to take care in the patients are very important. So, what is finally the ideal healthcare system? The treatment is based on the needs of the patients instead of the offer or the supply of treatment structure. We need to perform an ambitious patient empowerment program. Each age group is treated according to the disease stage with specific needs. And care for people with MS and more generally with brain diseases involve multiple specialties and numerous interventions with final outcomes which are determined by interventions across the full cycle of care. I would like to, Gilles has always been an innovative man. The first French MS clinic was created in Rennes with, it is a one-day evaluation for patients referred by primary care, GP or neurologist, a multidisciplinary team evaluation, which ends with a personalized care plan implemented during a multidisciplinary meeting. France has developed networks for MS patients. I don't want to develop this, but the majority of the region in France have at the moment networks which are very active in the field. A network in our region, it was the last Midi-Pyrénées. We organized and we create a network with the network which is called MIPSEP. You see in the center, and this network was involved in the care of patients at the social level and at the medical level. So in all the region was covered by this network. But, you know, if you see the public health as a funding institution, you have to take in account the cost. And so you have to take in account the value in health care. And the value is defined as the health outcome achieved per euro or dollar spent. This holistic approach toward seamless care models intertwines patients and societal outcomes with efficient spending resources. And we need a greater integration, as integration is defined as an organizing principle for care delivery, which improve patient care through efficient coordination and of service provided. This is the presentation of the cost which was published in Europe for all the brain diseases. Multiple sclerosis is there. And you see that for multiple sclerosis here, the medical cost, the indirect medical cost, and the indirect cost were, the rate is one-third, one-third, and one-third at the moment. But we have, at the moment, thanks to Christine Lebrun-Freinet, new insights into the burden and cost of multiple sclerosis in Europe, and particularly in France. And you see this by EDSS, the cost of the disease by EDSS, and you see it varies from 15,000 euros to more than 50,000 euros. And the shift between the type of cost, the green is the cost of treatments, and you see that the shift, the cost of green bar is lowering, and you see that in the final part of the disease, when patients are very disabled, the costs are completely different with community services, early retirement, and so on. So, healthcare has a cost. And I would like to remind you that also what is the cost of the treatments. This is a paper published in New Review Drug Discovery, not in September or October. And you see that the cost at the moment in the United States is $22 billion. And it will increase, and the anticipation for 2022, it will be 23 billion. And with innovative treatment, and probably a shift also in our strategies of treatments. So the neurodegenerative plan was launched after the evaluation of the third Alzheimer plan. It was launched with an enlargement of the perimeter of the main neurodegenerative disease, Parkinson's disease, and multiple sclerosis, which was considered as a neurodegenerative disease. Other neurodegenerative disease, particularly the genetics, are in another plan, which is a plan maladie rare disease. So the conceptual approach of this plan is first integration between medical and psychosocial care. Secondly, transdisciplinary approach in healthcare and research. And specifically, a new governance with active participation of patients and their representatives. It is a complex plan. I don't want to develop that, but there are four major strategies. One is for the healthcare and support throughout life and covering the entire national territory. The second is the adaptation of the society to the challenge of neurodegenerative disease. The third is the development of and coordination of research, which is led by my colleague and friend Etienne Hirsch. And finally, the governance of the plan. What is exactly the consequences for the different diseases for multiple sclerosis? The majority of the territory of national is covered by expert centers, and some are in progress for multiple sclerosis of labelization. And these expert centers with the network mission, and the network will continue, are there. Referral center for MS, care coordination, evidence-based guideline, protocol, care plan, educational training, share clinical record and participation to the OFSEP database, education of patient and training, clinical research, diffusion of innovation, and if as soon as possible, collaboration between the different expert centers for Parkinson, for multiple sclerosis, and for Alzheimer's disease. And there is also a new innovation in Brittany with the ONIRIC project, which is typically that we want to see to be developed in the different regions in France. So your question was, have we improved patient care system? I think we have improved our knowledge of the comprehensive management of patients with a disabling chronic disease and a complex treatment. Yes, I think we have improved the general organization of the health and social care setting, but I am not sure that the value of this care system at the level of the health-related patient outcomes has been improved, and we have to evaluate that. Finally, I would like to say that Gilles has always been an innovator, very interested also in the value of things. I found in these first publications this paper on the value of the NPTR in MH patients, probably for a new outcome of, I don't know exactly, what was the outcome you want to be evaluated. Do you know what is it exactly? I give the answer. Thank you, Gilles.